Hi all. Today our topic of discussion is going to be dental traumatology. So today in this video I have just put a PDF. It's a very important PDF for it's an international guidelines for treating all your traumatology cases, and it's a very gold standard article which we give even for our PGs also. So yeah, you can make notes out of this PDF, and same has been uploaded in the text portion also. So basically, before going into the individual types, there are a lot of classifications given for dental traumatology. But for undergraduation level, the classification given by Ellis and Davy is very important. You have to memorize all the 9 types of traumatology cases. And Anderson classification is also important. In Anderson, you would have spoke about what is an uncomplicated fracture, what is a complicated fracture, and all those. So yeah, those two classifications you have to memorize. And most important is Ellis and Davy. So going on to individual types, we'll be seeing this traumatology in two sections. The first section I'll be just handling the crown and tooth fractures. The second section will be seeing more about the luxative injuries, because amongst all the types, the most important question is your avulsion. A lot of questions come for avulsion, even in essay and short note. So moving on to our crown root fractures, the first most common trauma that can happen, and sometimes it go unnoticed, is an infarction. Infarction is nothing but a small minor crack, sometimes an incomplete crack, which sometimes it will be visible, sometimes it will be invisible, and the patient will be asymptomatic, no tenderness to percussion, and even if you do any pulse sensibility test, it will be positive only. Radiographically also you will not see anything. Treatment mostly does not require any treatment. If suppose you feel it compromises your aesthetics, you can probably cover it with a composite edge restoration. Okay, no need of any follow-up. Mostly it will pick up. Okay, so in this article you will be something you will be seeing some heading called as a favorable outcome and unfavorable outcome. This is not required for an undergraduate level, but I'll just tell what it is. So what their meaning is, supposing there is a trauma that has happened and you have done a treatment. So the prognosis of your treatment is being tabularized there, like favorable and unfavorable. If it is good, it means it's a favorable outcome. Like if the patient is asymptomatic and it's always pulp vitality testing is positive, and if it's an young immature teeth and tooth development is happening continuously, then it means it's a favorable outcome. The reverse is a unfavorable outcome. Okay. The next one is your enamel fracture. This again, it can happen most commonly. Okay, especially in your young adolescent and boy stage and all, because of sports and all those things, they will frequently get traumatized, right? So this is a very minimal fracture which happens only in the enamel portion. Again, the patient will be asymptomatic, no tenderness to percussion, normal mobility, and pulse sensibility will be normal. So these all points you have to write in clinical features. Okay, and radiographically also you will just see the fracture of enamel. Apart from that, you will not see anything. The one thing which we have to make sure is that the fragment that is broken, if it is getting dislodged in any soft tissue, this is what you have to check. Okay, and again treatment, sometimes just smoothing of a rough margin is enough, or you can go for a aesthetic restoration. And always remember, if supposing the broken fragment is available, the gold standard treatment is reattachment of their original tooth structure. Okay, and again follow up is very important, because any time the tooth may appear very normal, but after 1 year or 2 years it might go for a like what is a necrosis. So always follow up is very important. The next one is enamel dentin fracture. Here you will have two types. One is complicated, the other one is uncomplicated. So basically what is complicated? Complicated means if supposing your fracture line involves the pulp, it is called as complicated. If it does not involve the pulp, then it will be told as a uncomplicated fracture. So the line of treatment is very easy. You guys do in your regular OPD. So talking about the clinical feature, usually patient will not be that much symptomatic. It will be not tended to percussion. Mobility will be normal, and even pulp vitality will also be positive. Might be some patients will have mild sensitivity because of dentin exposure. Okay, if pulp is getting exposed, definitely patient will have tremendous pain. Okay, so these are the clinical features for both. Radiographically, again, you will be able to see the fracture line extending into the dentin, and if it is complicated, it will be involving till the pulpal level. And again, the fracture segments, if it is available, try to store it, or you see if it is getting dislodged in any soft tissue. Okay, coming to treatment. Treatment part is very important for this. See, basically, if the fracture is just involving dentin, as I always tell, if fragment is available, reattach it, or if not, you have to first evaluate what is the amount of RDT that is present. So what is RDT, remaining dentin thickness, because this actually gives a protection pulp. If sufficient RDT is there, like more than 2 mm is there, you can directly go with your composite restoration, or else you have to go for a proper pulpal protection, like you have to give a GIC base, or if it is less than 0.5 mm, you have to go for a sub base or liner. So most commonly that we use is calcium hydroxide or even MDA can be used. Understood? So this is the line of treatment, and the same applies for your enamel dentin with complicated fracture involving the pulp. So the same thing, see, always remember in both these cases, complicated and uncomplicated, always try to maintain the vitality of pulp. Do not directly jump into your RCT. If you think your pulp is still vital, probably you can go for your pulp capping procedure, direct or indirect, or you can also do a pulpotomy procedure. What is pulpotomy? Your radicular pulp is vital, just that your coronal pulp is inflamed. So you can just remove that portion of inflamed coronal pulp. So what is the advantage of doing this pulp therapies? The thing is that if supposing this traumas happen for an young individual wherein the root formation is not complete, probably if you do all these procedure, your normal root development can happen and can happen on its own. That is called as apexogenesis. So this is a very important concept and line of treatment. And if you think the tooth is completely gone, and if you think the tooth is completely gone, then you can directly go for your normal pulpectomy procedures. Okay. Now coming to your next part, your crown root fracture. So initially till now we saw only the crown fractures. Here the fracture is extended below the gingival margin to involve the root. Again here also you have two parts. One is complicated and uncomplicated. So if it is uncomplicated, see, always remember in crown root fracture the main problem is that patient will be extremely symptomatic because of the mobile segment. So you have to either remove the segment or you have to immobilize the segment. This should be the first line of treatment. Okay. So always keep this in mind. So the first scenario which we are going to see is that here the fracture line is not involving the pulp. Okay. So obviously, as I already told, the coronal fragment is mobile, so patient will be little sensitive. I mean, he'll be having some pain. And treatment part, as an emergency treatment, either you will have to immobilize the fragment or you will remove it. Okay. The next definitive line of treatment will depend upon the stage of involvement. Okay, probably you can do a composite restoration, like you can remove the fragment. If it is available, you will reattach it. I mean, if it is possible to reattach, you just mobilize it and absorb, or else you just remove the fragment and give a proper protection to the pulp and then proceed with your permanent restoration. Supposingly, if you feel the axis is not there because the fracture is extreme subgingivally, probably what you can do is that you can expose the subgingival portion. Like how you will do, you can do a gingivectomy or osteectomy, or you can do a surgical extrusion or orthodontic extrusion. So by doing it, so you'll be able to bring the tooth to the occlusal position. Then you'll be able to visualize the fractured site, wherein you can place your restoration. Understood? So again, if it is involving pulp, then the line of treatment should be like how I told initially. You have to always focus on your root development to happen. You should never directly remove the pulp tissue. You have to always preserve the vitality of the pulp. So as I already told, if it is involving pulp, always try to protect the vitality of the pulp by doing a pulp capping, pulpotomy, or else you can probably proceed with your normal endodontic treatment. And here, if you are doing an endodontic treatment, the problem is that the restoration is again a problem. You have to first extrude the tooth, and then you have to gain the access to that area. Then, depending upon the amount of tooth structure remaining, probably you can go for a pose and then proceed with your permanent restoration. Then finally root fracture. So sometimes the fracture will be happening in the root portion, not involving the crown. So if it is happening in root, again it can happen either in the apical third, middle third and coronal third. Always remember, there is an important question that they will ask, among all these sites, which has got a favorable prognosis. More apical the fracture length, better is the prognosis, because in apical portion you have a rich vascularity and it can heal on its own, and mostly it will maintain its vitality also. Supposingly, if the fracture has happened at the coronal segment, the prognosis is the worst prognosis, because all of your root portion will go non-vital. You have to eventually go with your RCT. You cannot try any of this vital pulp therapies. And the problem is that it is constantly being exposed to your oral environment, and more chances of bacterial contamination can happen. So the worst prognosis is always coronal segment fracture. The good prognosis is apical segment fracture. So again, the treatment, you have to always make sure here in all these cases, root fractures or not, patient will be symptomatic. The first thing you have to do is that you have to give an LA and you have to go for a splinting procedure. So how much duration you do splinting is an important question. You have to go for a flexible splint, and for apical and middle third, probably a 4-week duration is more than sufficient. So if it is involving coronal third, a little longer duration is advisable, probably 4 months of splinting duration. So always remember, you will always go for a flexible splint and not a rigid splint, because flexible splint will allow your normal physiological movement to happen for the patient. At the same time, you can also avoid the chances of ankylosis. The next one is your alveolar fracture. So what is alveolar fracture? Fracture involving the alveolus. So this you would have seen in the clinical OP. So if you palpate and see, you can see the complete segment is moving. Okay. So again, what you can do, the first line of treatment is you have to mobilize. Okay, patient will be symptomatic, you have to mobilize and you have to observe. So you'll give a flexible splint for 4 weeks, then you'll recall the patient, you'll check the vitality of the teeth. Mostly it will go for a non-vital case only. So you'll go with your proceed with your RCT, and regular follow-up is very important, because all these root fractures and all now, once it happens, mostly the root will go for non-vitality. I mean pulp necrosis. And one more problem is that the most common sequelae of all these trauma is resorption. Definitely, if you're not following it properly, it will go for resorption, external surface resorption or inflammatory or any kind of ankylosis can happen. So always please have a regular check follow up for all these cases. So with this we'll wind up. The next part we will be seeing in another video.